Hi guys, and welcome back to another episode of To Be Honest, the podcast. If you're new here, my name is Annabelle Burgess, and this is a health education podcast.
Actually, to be honest,
Actually, to be honest,
Actually, to be honest.
My goodness, it has been a minute since the last episode. I think it's been like 2 weeks, but even though there's no episode that has come out, I have been flat out. Like, when am I not? But this last 2 weeks has been nuts. If you have sort of like watching the visual episode, you will see that we have got a change of scenery, and that is because I have been able to move the podcast studio into my new apartment, which has just given me such a relief. It's so much more flexibility. It means that I can sort of navigate full-time work as a nurse with the podcast, releasing that content, social media, and also just my life routine and things that I need to get done. But it has been a really exciting time. I have a lot of stuff in the works with my own social media and with the podcast. We have some amazing guests coming up as well, and a few mini series that I'm really excited about. So that's all exciting stuff that's going to be coming up later in the season. So today's episode is called My Head and My Heart, which is on strokes and heart attacks. So it's covering sort of like neurology, which is like for the Grey's Anatomy fans, that's like your Derek and Amelia Shepherds, and then we're going to be covering like heart attacks, so everything to do with your heart, your cardiology, your circulatory system, and that's like your Christina Yang specialty. So it's a very complex episode, but I've gone through everything to make sure that it is easy to learn and understand, but also not like dumbing things over, like actually giving you guys a really good understanding, because at the end of the day, these are two extremely common diagnoses. Unfortunately, they are both very high risk and have a high mortality rate. So it's just important that you have that understanding and education so that you can prevent it. You can also see the early warning signs, and you also know what's going on if, say, a family member, a loved one, a friend has, posted on social media or contacted you letting you know that this has happened. Then it's not just, they've had a heart attack, that you actually understand what's occurred for them to be in this situation. So it should be a really good episode. So if you're new here, we start every episode with a baby pod. A baby pod's just kind of like a little rundown that's somewhat irrelevant to the episode, just a little health update. So today's baby pod is kind of going to be on routine and rituals. But I think at the core of showing up as the best version of yourself is definitely finding that routine and that daily pattern that helps you show up as the best version of yourself. So that is extremely challenging for anyone who's on some sort of shift work or rotating roster, because routine just doesn't exist in your life. So I like to use the word rituals, because that is me making a commitment to a repetitive action that I'm doing in a 24-hour period. So for me, some of the rituals that I commit to in a day is making sure that my diet has vegetables in it. That, like, anyone can find their own rituals, but for me, having vegetables in my diet helps with my digestion and my stomach health. So veggies, I have a tea that I drink every morning. I think I've spoken about that on the podcast before. Well, I have it like first thing after waking up, whatever time that is. I like to exercise in every 24-hour period. I also really like doing my skincare. That's just something that helps me physically show up as the best version of myself. And, everyone's different, but for me, when I physically look my best, I feel my best, whether that's in, comfy clothes, I have like a nice tan on, I've had my hair done, all of these like little things that might seem superficial. For me, they are my rituals. They're things that help me show up as the best version of myself. So yeah, I think having those rituals every day or in a 24-hour period are just little things that are going to help with your personal growth. And it's just improving a few little things in yourself. Another really important ritual is like waking up and not going on your phone first thing in the morning. It sounds really cliche, and I know a lot of like people talk about that on social media, but like the truth is, when that's the first thing that your brain sees and receives every single morning, then that's just gonna like impact the rest of your day. So just like maybe make that a ritual for the days that you wake up, the first thing you do is you have a coffee and you step outside, or you open a window and you get fresh air. That little thing can become your ritual, and have just a couple of them in a 24-hour period, and you'll already start to feel that improvement in yourself, because that will impact your physical and mental health as well. And I work in a team nursing ward, so we have, a really big team environment, which is a great team. I love them, but I can show up as the best version of myself to work when I am completing my little rituals in my personal life. So it's all about the impact that you have on people around you and the people in your community as well. So, even if you're someone who does work at home or work from home, you are still going to be interacting with people, whether that's online or, at Woolies. But, it's just being that best version of yourself comes from those little rituals that you can do in a day. So that's my little baby pod for this week. You take anything away from that, just change a couple things in your day or commit to a couple things every day as your rituals, and just monitor that and see if that sort of improves the way that you show up each day and become the best version of yourself, so that you are working on your best physical and mental health. All right, let's get into it. Okay, so this episode is on my head and my heart, which is about strokes and heart attacks. The first one we're going to dive into is heart attacks. It's like big, scary word, heart attack, and not the Demi Lovato song, even though it's a banger. And it's now going to be stuck in my head for the rest of this episode. So there are 3 types of heart attacks that we're going to cover today. And these are the more common presentations to emergency, and most likely what you will sort of see with family and friends, unless there is like major cardiac illness and disease and history. But these are the 3 more common types. So we have a first up, which is a STEMI, STEMI. And then we have a non-STEMI, which is the same spelling, just with a non in front. And then we also have unstable angina, not vagina, angina with no V. So without a V. So they are our 3 types of heart attacks that we're going to cover in today's episode. So first up, we have STEMI. So STEMI refers to a blockage in the coronary artery caused by a buildup of atherosclerotic plaque. So like fats and cholesterol that is circulating in the blood. Potentially your levels are too high and they start to form clots, and that clot can either sort of build up on the side of the coronary artery wall or sort of pass around until it gets lodged, and then that creates a full occlusion of blood flow to the heart. Your heart can't get that blood and you go into this sort of cardiac distress, and all of these complications happen with your organs, and obviously you're not getting oxygen around your body. All of these things are happening secondary to the fact that there is a blockage. How do you know that you're having a heart attack? Some people can experience a more sharp tightness of like chest, unable to take a deep breath, and that pain can radiate to the left shoulder. It can also radiate to your back, but either way it'll sort of be like that chest related pain. Some other symptoms you might experience are sort of like sweats, this like hot feeling. I haven't experienced a heart attack firsthand, but these are our common symptom presentations. And also potentially like a fluttering feeling as well, being unable to catch your breath. The most important part when understanding that symptom is that it won't be resolved by movement. So often if you've like pulled a muscle, you've been sitting in a car for too long, and then all of a sudden it's really tight in your chest and you're finding that sort of like there's this pain, it might be radiating to your back. If you find that when you roll your shoulders forward that you can kind of get some relief, or when you lie back or when you lift your arm, it's sort of making the pain worse or better, then it's an indication that it's potentially muscular related, because if you are having a heart attack, then that's something that's happening within that the cardiac walls of your heart, and that is not going to be affected by movement at all. So that's an important sort of like understanding as if like to whether or not you're having a heart attack if you're at home. Dizzy, seeing whiter light. These are like your main symptoms to keep an eye out for any sort of heart attack. But that's absolutely what you should be like calling 000 and getting straight to a hospital. I would not drive. Absolutely do not get in a car and be like, oh, I'm just going to take myself down to get checked out. No, call an ambulance, or like, get there as soon as possible, but do not drive yourself behind the vehicle, because heart attacks are very unstable and at any point in time you could lose consciousness. So never just like take yourself down if you think you're having a heart attack. So how do we diagnose it once you get to emergency with these symptoms? We're going to do something called an ECG, electrocardiogram. And what we're going to do for that, we can do a 12 lead ECG, which is when you're going to lie on your back. We'll have to remove your top. We'll have to remove your bra, so there's like no wires. Also like your necklace or any sort of jewelry, so that you're as bare as possible. And then we're going to apply these little stickers under the left breast or the left pec, and also on your upper limbs and your lower limbs. So that is what it's kind of going to look like. And then we are able to sort of trace the sort of electrical signals that are being sent out from your heart, like that contractions and everything that's occurring. And we can identify whether or not there is a misfiring signal or there is a complication within the heart and, it's all out of whack. It's really fascinating. I don't really like analyzing ECGs. It's very stressful. Obviously, you can get things like infarct in the reading, and then it just like blows my mind that people can analyze them so accurately. But anyway, that will then be reviewed by the emergency doctor. So in addition to an ECG, you are then going to have bloods done immediately, and you're going to get a cannula put in your arm. So we're going to take bloods, and the big ones that we're going to be looking for are D-dimers and troponins, as well as your Chem20 and everything else. But the troponin blood test is going to tell us if there's been any damage to your heart, because that is something that's troponin is released into the bloodstream when there is trauma inflicted onto the heart. So it's a really clear understanding as to whether or not there has been that sort of blockage or occlusion in the arteries. And that will come back really quickly and give us a really good understanding on where we're sitting with your heart attack. But the STEMI is going to show up on an ECG. So we'll have bloods as well, but we are able to diagnose a STEMI heart attack based off an ECG. So how do we treat a STEMI? We are going to put something in, because obviously a STEMI is life-threatening. So we are going to treat it by putting you on blood thinners, but also, which we can administer IV, intravenously, but also we're going to be giving you some GTN spray, which is something that is like a vasodilator, so it will blow up your vessels and allow for some like space. But if there's a full blockage, we're like, this is an emergency. We are going to be sending you off to the cath lab, the cardiac cath lab, which is a cool little place not too far from emergency, where you are going to receive a stent. This is something that will happen while you're awake, or potentially sedated. I mean, it kind of depends on the situation, but more often than not, you can receive a stent while you're awake, but you're given heaps of medication. Then they will do a coronary angiogram, which is like they'll put CT dye into your cannula, and they'll use a big machine to sort of see and identify where the blockage is. And then using doing a PCI, which is when they are going to get this like little catheter, and kind of similar to like when you get a catheter put it in your urethra to help with your bladder control, or a catheter put into your vein to help like with that. Like, it's just like a plastic tube, right? But it's going to go up. They're going to feed it up from, say, it's like down here at your arm or up here in your arm. It could be like wherever they go in, most likely up here. They feed up through the vessels, again, watching the scan as they do it live, and they pop this like little balloon with like mesh on it all the way into where the blockage is, and then they inflate the balloon a little bit, and then they remove the balloon, leaving behind this like little mesh stent, which is holding open the like vessel, the blood vessel, and passing the clot, whether or not they need to remove it, whether or not they are able to sort of flush it out with blood thinners. That's sort of like very depending on the situation, but you get left behind with a stent. And that is because once that plaque is removed, you're still going to be left with trauma to the vessel wall because it's like scratched at. It's like the integrity is really bad. So the vessel wall will be protected by the stent, that little mesh stent left behind. It's absolutely fascinating. Like, it's so cool. You can be lying there awake the whole time and they're just like putting this little mesh, like little patchwork on the inside of your vessel. Like, blows my mind. It's crazy stuff. Crazy, man. Anyway, that's what a PCI and a coronary angiogram is. It's pretty dope. And that's all done in a cath lab. So if your dad or someone you know has had a full occlusion heart attack and they've had to get a stent, that's what's happened. It's pretty quick and just in and out. I mean, it's not that quick, but like, it's not a major operation. That's how we diagnose a STEMI. How do we diagnose a non-STEMI? So a non-STEMI is not a non-heart attack and it's not a non-occlusion, even though the word suggests otherwise, but it's a partial occlusion. So if you have plaque buildup in the coronary artery wall, but it's not fully occluding. So you are still getting some blood flow, but you might be experiencing that chest tightness because you're not getting sufficient blood flow. How do we treat it? Very similar. We're not going to know if you're having a full heart attack or a non-STEMI when you present, because obviously the symptoms are the same. So you'll come in, we'll do an ECG, but we're not going to be able to see a full occlusion on the ECG, on the like we would with a STEMI. So we'll do some bloods, and the blood work might come back saying that your troponin levels, which is what's released when there's trauma to the heart, is high. So that's indicating that there is currently something going on in your heart that's not great, and that there is some trauma inflicted onto your heart at that current time. We treat non-STEMIs with anticoagulants and antiplatelets. So you might be started on a heparin infusion, which is like a blood thinner. You might be just given a whole bunch of like intravenous blood thinners. A few other little fun things. But you will then, from then on, most likely be seeing a cardiologist, a specialist, and they will start you on some cardiac medication to prevent you developing a STEMI, a full occlusion down the track. The other thing with a non-STEMI as well, which is why we're not just going to give you a couple pills and discharge you, is that non-STEMIs can develop into a STEMI. So just because there's a partial occlusion now doesn't mean that in 6 to 12 hours to 24 to 48 hours time, you can actually develop a full occlusion. So that is where, medicine is extremely important to be following those policies and guidelines, because, we can't just send you on your merry way. So if you present to emergency and like, oh, it's not a full occlusion, here's some medication, and you're like, nah, I'm right, I'm just going to go home. Just don't discharge against medical advice. Just don't do it, because we're only looking out for you. It does happen. People do yeet out of there. Depending to the amount of trauma that and the clot size, because they might do an angiogram on a non-STEMI as well, depending on your history. And if in that case, they may decide that they're going to put a stent in with a non-STEMI as well. So, they might just spice some things up. And then moving on to our third sort of type of heart attack that we are covering, that is a unstable angina. So what's kind of happening when we have unstable angina is that we have this sort of constriction of the coronary artery. Even though there's no blockage, there's no sort of plaque buildup, the vessel itself is under more pressure. And then obviously we can't just brush this off and be like, oh, well, you're not having a heart attack, or I should say a life-threatening event. At the time, obviously the longevity of that coronary artery's integrity, some bit of a mouthful of words, is that it's sort of going to deteriorate. So eventually that heart muscle is going to sort of either lose its vascularity or kind of just deteriorates. So we still have to treat unstable angina as an emergency situation because it can escalate, but we just don't have to treat it as severely as a STEMI or a non-STEMI, which are more life-threatening at the time. So yeah, we do. And how we treat that is with a GTN spray. So that is a vasodilator, which essentially expands. We very briefly touched on it earlier, but it expands the blood vessels, and that allows for more blood flow to come through. Just before we wrap up on cardiology, I just want to cover the sort of really common question when it comes to heart attacks, and that is it genetic? And what does that mean if it's genetic? And also if you're at a GP or if you're getting a healthcare workup, they might be like, hey, does anyone in your history have a cardiac history? Does anyone in your family have a cardiac history? So what that kind of refers to, so if your dad, let's just use that example. If your dad has had a heart attack and they've put that down to, say, a STEMI, there's been an occlusion and a blockage due to a buildup of cholesterol and fats and plaque in the bloodstream. That sort of situation is not considered genetic. So just because your dad had a blockage in his heart doesn't mean you're going to have a blockage in your heart. That's more sort of that's more sort of situational to the health of that human. So when we are referring to genetic cardiac conditions, we are referring to situations like cardiomyopathy, which is referring to the integrity and the health of the heart muscle. And this can be a genetic condition where potentially you have a derivative of cardiomyopathy that causes a hardening of the blood vessels and the coronary artery, or the weakening of the muscles. So those kind of variations of cardiomyopathy, there's so many of them, but those conditions are more hereditary and more genetic. And you can get tested by doing DNA testing. You can also get a simple blood test. And like I said earlier, there are so many scans that you can do to check, to get scans and imaging done on your heart as well. So yeah, that is cardiology. If you have any questions on cardiology, please send a message direct to us on Instagram or social media, and we can cover and answer any of your questions. So next up, we are talking about neurology with an N, neurology. And that is your Derek and Amelia Shepherds of the Grey's Anatomy world. And that refers to our brain, the science and medicine around our brain. And it's different to mental health. Neurology and mental health are two different specialties. And today we're going to be covering that science, anatomy, and medicine of the brain, which is neurology. So when we come to a stroke, we're going to cover 3 strokes today. And these are the 3 types of strokes that you could present with. So unlike a heart attack where there are sort of multiple variations of a heart attack, when it comes to a stroke, there's really only 3. And that is our ischemic stroke, our trans-ischemic accident, which is a TIA, or a hemorrhagic stroke. When we are looking at those 3, we're sort of going to divide them again. So the trans-ischemic and the TIA, the first 2, they're similar to our STEMI and our non-STEMI. So they are occlusions in the blood vessels in our brain, so stopping the blood flow because of that buildup of plaque. Whereas when we talk about a hemorrhagic stroke, we are referring to something that is actually hemorrhaged, so a burst blood vessel that is sort of like bleeding out in our brain. So there's sort of 2 types. We've got ischemic, TIA, and hemorrhagic. So to touch on an ischemic stroke, that is very much like our STEMI in heart, but our ischemic stroke is when we have a full occlusion in a blood vessel in our brain. So there's been a cessation of blood flow through that vessel, meaning that that part of the brain is no longer able to sort of get rich oxygen and function properly. And then when we have our TIA, which is a trans-ischemic accident, that is like our non-STEMI, where it's a partial blockage. However, this is sort of like a little thing to remember, especially if you're like studying medicine, nursing, anything health, and this comes up in an exam. Your non-STEMI refers to a partial occlusion, usually requiring intervention to pass that, right? But when we have a TIA is a partial occlusion or an occlusion that passes short term. So it's trans-ischemic accident. It's a short-term thing. Whereas our non-STEMI was a partial occlusion of blood flow, our TIA is a short self-resolving accident. So they're not exactly the same. That's just like a little, to not like confuse anyone. But a TIA is essentially a clot or a partial clot that passes. So you might experience symptoms that sort of resolve, and then you're like, oh, that was a bit weird. I don't really think that was maybe happening for half an hour. Then it sort of resolved itself and you went about your day. So they're a little bit more dangerous because we tend to think that things that self-resolve are sort of brushed under the rug. However, it is also a stroke, and it has so many complications and comorbidities that can come from that. So it's equally as serious as a stroke. The next type of stroke we have, so we've got our ischemic stroke and our TIA, which are our occlusions. Blood flow has been occluded in the brain. Our next one is a hemorrhagic stroke. Hemorrhagic strokes, this is when we refer to like bleeding on the brain or sort of an aneurysm. So our most common causes, okay, I'm going to say in my experience as a nurse in emergency, the most presentations I get for hemorrhagic strokes are trauma, sort of like a cerebral aneurysm, which is more often than not caused by uncontrolled hypertension, which is high blood pressure, uncontrolled, not taking your pills, sort of been generally unwell for a really long time. Blood pressure is sitting nice and high. Sometimes the vessels in the brain can actually burst before the heart gives out. Drug abuse is also a really, really common one for a hemorrhagic stroke. where, just that pressure that puts on the cardiac system just increases the blood pressure, as well as the way that it reacts to all of the firing mechanisms in the nervous system as well. And eventually the brain just can't handle that sort of stimulus. And as a result, the sort of similar to an aneurysm, the blood vessels just end up bursting and you end up having a hemorrhagic stroke, which is very, very sad. Unfortunately, I had a patient recently who was a 20-year-old female. She had she'd tried cocaine for the first time, took it from a mate in one of the bathrooms in Brizzy, and as a result had a hemorrhagic stroke, first time ever using recreational drugs. Very, very sad situation, and unfortunately she will have left side paralysis for the rest of her life because she had the stroke. She obviously fell unconscious, was very unwell in the bathroom. It all happened very quickly, and then the friends and everyone around her who was also aware of using the illicit drugs was not wanting to sort of contact emergency services. There was time wasted trying to assess the situation, and by the time emergency services had intervened, it was not a good situation. So when it comes to strokes, what are our symptoms? So thankfully, we sort of had the same symptoms for any type of stroke, and that is what we refer to as fast symptoms. If you're, say, let's use the example of like a grandparent, and you're sitting with them and all of a sudden you think that things aren't quite looking right on their face. Potentially it's looking a little bit lopsided. A really quick check is to get them to raise their eyebrows, because when you raise your eyebrows during a stroke, then one of your eyebrows will raise and the other one won't be able to raise. Because there's been that interruption during the occlusion or the hemorrhage, then you're actually going to end up with that left-sided or right-sided weakness. So they won't be able to raise their eyebrow. The other one is get them to give you a smile. So eyebrows and smile, that's like the two quick checks for face. For facial drooping, the next one is arm weakness. So what you're going to get them to do is hold your hand and squeeze your hand, or hold a pen or something that's nearby. The next symptom is sort of slurred speech, and that is when they're incoherent, mumbling words, unable to sort of use their tongue to pronounce the words correctly. And none of these are sort of in like order. It's just a really good way of remembering the three main symptoms: facial drooping, arm strength, and slurred speech. But you can have slurred speech and none of the other symptoms. So they're not dependent on each other. They're just indications of a stroke. So if you're with your family and you're like, oh, they can't, lift their eyebrow, they're drooping on one side of the face, but I can kind of understand them and they can hold things and their arms are moving, oh, it's not a stroke. That's not correct. If they have any of the following symptoms, they could be presenting with a stroke. Then the last letter in fast is T, and that's time, and it's time to escalate. So we're going to call an ambulance and get this investigated. So a really big thing then is once you've called the ambulance, what you have to do is to start that timer. And much like, this is going back a little bit, but in one of our first episodes when we did It's a Medical Emergency, we talked about if you ever have someone who's lost consciousness, starting that timer on your phone immediately, same as a stroke, because these are two time crucial diagnoses. So when it comes to treating an ischemic stroke or a TIA, then one of the things that we're going to use to treat that is thrombosis or thrombolytic therapy. And that is a way of breaking up the clot in the brain. But because of the invasiveness of that operation and the risk, there's a lot of sort of requirements to be a good eligible candidate for that therapy. And one of them is the amount of time you've had restricted blood flow. Standard practice in Australia, in Queensland, New South Wales, is that we have I think it's max 4.5 hours from the initial symptom to no longer qualifying for thrombosis, which is a life-saving treatment. Because the longer you have restricted blood flow due to a clot or a hemorrhage, but in this case we're talking about clots, then the more brain cells are dying, because our brain needs oxygen-rich blood. What we are looking at here is that every minute that you're experiencing a stroke, at least 12 million brain cells are being killed. So that's a lot, and we have a lot, but what's happening is when those brain cells die, we are becoming a higher risk. So whether that is losing ability to speak, losing ability of one side of your body, movement, all of those things. It could be continence, so being able to hold your wee. Little things like this are all affected by our brain and controlled by our brain. So the longer that the TIA is, or the ischemic stroke is occluding blood flow, the higher risk you are of having long-term symptoms and long-term comorbidities. And that is why time is so important in our fast, because setting that timer means that by the time your family member, whoever it is that you've called the ambulance for, gets to the hospital, then the emergency services then know how long the stroke has been going for. So obviously we've got two severe situations here. We've got the ischemic stroke and we've got the hemorrhagic stroke. We've got the blood clot and we've got the brain bleed. You treat these two polar opposites, because one of them we need our blood to thin, the other one we need our blood to clot. So completely different. That is why it's very important to diagnose them correctly. If you present to emergency with stroke symptoms, we're able to do a blood test to see if you have high clotting factors in your blood, which is called a D-dimer test. And that will tell us if there is like a big clot in your blood, in which case we would be like going down that more ischemic path, because you obviously have a big clot and your clotting factors will be really high. And then the other one, which is very definitive, and of course we would always do before starting a course of treatment, is a CTB, which is pretty much a scan of your brain. And that will identify, it'll be done under contrast, and that will identify whether or not there is a clot or if there is a bleed in the brain. So that imaging allows us to identify it, and they're both treated very differently. So in our first ones, like we were talking about thrombosis, thinning the blood and passing that clot, that is for the ischemic stroke. And in a hemorrhagic stroke, we are going to treat that by clipping the aneurysm, clipping the sort of vessel that's burst, and kind of like how you'd put a stitch through your skin if it was bleeding out. You're kind of doing a little stitch, but it's a metal clip that goes into the brain. So it's absolutely insane that we're able to do this. It is very time sensitive and obviously has to be done as soon as possible so that there's as little long-term effects as possible. And then obviously they look at the clotting factors as well to stop or slow that release of blood and that bleeding out. All right, so let's do a quick summary on today's episode because it was a lot. So firstly, we covered my head and my heart. So we had cardiology, which was referring to our heart, and we covered heart attacks. There were 3 types of heart attacks that we covered today, and that was our STEMIs, our non-STEMIs, and our unstable angina. Our STEMI is our full occlusion of blood flow to the heart. Our non-STEMI is a partial occlusion, and our unstable angina is that cramping and that sort of pain that's related to the cardiac wall, which isn't an occlusion but still increasing blood pressure and lots of complications. So it is still considered a heart attack. And we talked a little bit about genetic, and then we covered our brain, and this is where we talked about strokes. We covered 3 strokes today, and that was our ischemic strokes, which are a full occlusion in the blood vessels in the brain. We covered transischemic accidents, or a TIA, and that is a temporary occlusion which self-resolves but still needs emergency treatment. And then we have our hemorrhagic strokes, which is our brain bleed. So when we talk about strokes, we got to be super important to remember FAST, which is our symptoms and initiation acronym. So starting that timer the second we notice someone else's or our own symptoms, so that we're able to give them an understanding of our time frame so that we can get the correct course of treatment. So that is this episode, My Head and My Heart. Thank you so much for everyone for listening along. And obviously we have the visuals up on YouTube and TikTok and Instagram, as well as the audio, which is available anywhere that you get your podcast. Make sure that you are following or subscribing and liking along, because your support and feedback is very important to me. So thank you very much. If there are any episodes that you want to see, don't forget to DM us or let us know, or if you have any questions on today's episode. Thank you so much, and I hope you have a beautiful week. Make sure to stay well and healthy. Bye.